to the Friday Five here on the Agent Survival Guide podcast. It is Friday, October 11th, and this is our weekly list of 5 things you should know about. I'm your host, Sarah Ruppel, and what a week it has been. Let's start with our countdown to AEP, which is now in single digits. 4 days left until the start of AEP on Tuesday, October 15th. Also, at the time of this recording, we are still waiting on the Medicare Part A and B premiums and deductibles for 2025. CMS should be announcing those very soon. Last year, they came on the Friday before AEP started, so hopefully we will get those later today. Fingers crossed. Moving on to this week's list, we'll start at number 5 with the Department of Health and Human Services and the Centers for Medicare and Medicaid Services announcement of their final guidance on the second round of the Medicare drug price negotiations. At the end of August, you might recall that we reported on the prices negotiated by CMS for the first round of Medicare prescription drugs. Last week, CMS announced their final guidance on round 2 of Medicare prescription drug negotiations, which are set to begin in 2025. According to the fact sheet, CMS can hold a town hall meeting and up to 15 of what they call patient-focused roundtable events as they're working through the selection process. The first part of the process involves CMS naming the drugs selected for negotiation. The deadline for drug selection is February 1st, 2025, and the list can include up to 15 Part D drugs. Prices for the second round of selected drugs would then begin negotiations going into effect for coverage year 2027, beginning January 1st. Number 4. On Tuesday this week, we published our interview with Ross Baker from Health Sherpa, where we talked about a lot of the changes coming to the ACA for open enrollment this year. And then on Friday last week, HHS published their Notice of Benefit and Payment Parameters for 2026 Proposed Rule, just days after my interview with Ross. So we will have to have him back after he's had some time to read through that legislation and process it. Couple initial thoughts here. First, we got the 2026 ACA Proposed Rule slightly earlier than last year's version. Interesting that it came out before OEP and AEP. But when you look at the date of last year's proposed rule, that came out on November 15th, 2023. And we all know what takes place on Tuesday, November 5th, 2024. So interesting, yes. Surprising, not so much. I would wager that we might see something similar on the Medicare side of things. But let's talk a little bit more about the ACA proposed rule. One of the areas focused on in the proposed rule, more oversight from CMS on dealing with unauthorized plan switching. That is something Ross and I talked about more in depth than what we've discussed here on the show previously. In the release, they said, quote, if CMS determines that an agent or broker poses an unacceptable risk to marketplace operations or marketplace information technology systems, we will use our existing authority to suspend that agent or broker's ability to transact information with the marketplace itself. CMS is proposing to expand its authority to suspend an agent or broker's ability to transact information with the marketplace itself if we discover circumstances that pose an unacceptable risk to the accuracy of marketplace eligibility determinations, operations, applicants, and or enrollees, end quote. So essentially adding on authority in the area of eligibility determinations, applicants, or enrollees, in addition to their current oversight of operations and information technology systems. CMS also proposed a way to cut down on the potential trigger of the grace period that begins when a member fails to pay their premium. Plans could choose from 3 premium payment threshold options, one that CMS would cap at $5 or less, a net premium threshold of 95% or higher, or a gross premium threshold of at least 99%. Another issue addressed in the proposed rule, allowable silver loading. The term is defined by CMS to occur, quote, when issuers raise premiums for their silver plans to offset the cost of providing cost-sharing reductions that lower the amount consumers pay for deductibles, co-payments, and co-insurance under those plans, end quote. CMS is seeking public comments on allowable silver loading, quote, when the adjustments are reasonable, adequately justified, and follow state law, end quote. Next thing I noticed, 2 sets of potential user fee rate increases for 2026, depending on whether or not ACA subsidies from the Inflation Reduction Act are renewed past coverage year 2025. If the subsidies are not extended, the user fees will increase to offset the projected drop in enrollment. FFM user fees would go up to 2.5% of monthly premiums, while SBM and SBM-FP user fees would increase to 2% of monthly premiums. If the subsidies are extended, the rates will still increase, just not as much, given that enrollment should stay around the same as it is now. FFM user fees would increase between the range of 1.8% and 2.2% of total monthly premiums. As for SBM and SBM-FP users, those would come in between 1.4 and 1.8% of total premiums. And then the last item that I'll mention here today from that proposed rule, switching the failure to file and reconcile, or FTR, rule from its current form, in which those who fail to file are no longer eligible for an advance payment of the premium tax credit, or APTC. It would change the FTR rule to cover 2 consecutive tax years rather than just 1. Interesting proposal there, and of course, that is just skimming over the proposed rule and pulling out what I found interesting. We will continue to look through the proposed rule for highlights to mention in upcoming episodes. Just wanted to talk through those initial items here today, and we will have the link to read the proposed rule for yourself in the episode notes. Number 3. Back when iOS 18 was announced, we were told that many of the new features would be powered by Apple Intelligence. And then when the new iPhones were announced in September, we learned that we wouldn't get any of those new AI features until later on in October. Now we have a rumored date for the first wave of Apple Intelligence, thanks to Mark Gurman from Bloomberg, who is often very reliable with his news and updates. According to Gurman, October 28th is when Apple will release iOS 18.1. In reports that I have read, iOS 18.1 will include writing tools like proofreading, changing the tone of writing, creating summaries and notification summaries for a few different apps. In Photos, we'll be able to create memory movies from a prompt, as well as utilize the cleanup tool to remove unwanted items from the background of a photo. Also in that update, Siri will purportedly get her glow up. Probably important to mention that when the Apple Intelligence features launch, they will launch in beta. From what I understand, Apple Intelligence is very much a work in progress, with additional features coming in December of this year and then stretching into next year. And yes, it might feel like an S year as far as upgrades go, that there's not really enough new to warrant upgrading, but I would disagree. I can't say that I have buyer's remorse. I'm still happy that I went with the 16 Pro Max. But I have seen a lot of reports that some users went with the regular iPhone 16 and they are perfectly happy with that choice. I can't say that I don't love the pink iPhone 16 and the 2 other colors, but I certainly didn't love them enough to actually switch from the pro version to the regular version. Your mileage may vary, but we shall see what drops on October 28th, so make sure you're following along with the show because that will likely make it into the November 1st edition of our Friday 5. Number 2, last week, Cigna sent out an email update to brokers regarding Healthcare Service Corporation's agreement to acquire their Medicare Advantage, supplemental benefits, Medicare Part D, and Care Allies businesses. We wanted to mention that email here, just in case you missed it, because it does cover some questions that we've been getting about the acquisition and what it means for agents during this AEP. We've seen it before that when acquisitions happen in a lot of different industries, not just ours, sometimes the rumor mills start going. So we're trying to amplify what we've been told by Cigna. And that is that for now, it is still business as usual. HCSC and Cigna still expect the acquisition to close in the first quarter of 2025. Until the acquisition closes and changes are announced, the two Medicare businesses will function as separate companies, Cigna's Medicare business and HCSC's Medicare business. There are 5 points from the email that I would like to mention here, and I am reading this from the email verbatim. 1. Medicare plans will continue to be offered and sold under each company's respective brand for the 2025 plan year. We will continue to evaluate the integration between both companies beyond the 2025 timeline and will share updates as they become available. 2. Since the transaction is expected to close in 2025, there will be no changes to Medicare Advantage plan benefits or premiums in plan year 2025 for either company. Medicare supplement plans will follow state filings. 3. Cigna and HCSC's customers will remain enrolled in and covered by their existing 2025 plan upon the close of the transaction in 2025 for the duration of the 2025 plan year. 4. The group retiree business will remain business as usual, and Cigna and HCSC representatives, respectively, will be in contact with you along the way for all of the exciting changes this brings to the market for you and your clients. 5. It is important to remember that immediately after the transaction closes, we will continue to operate as two separate plans. Post-close communications will provide specific details on how the companies will move forward. So as far as this AEP is concerned, it is business as usual. The two companies are functioning as separate companies with no planned changes to 2025 coverage as a result of the acquisition. As far as when there are changes to report, well, that is one thing that you can count on us for. Definitely recommend following along with our show to stay up to date. And if you have questions, you can use the contact information in the notes to reach out and ask those questions. And now on to our number 1 story this week. CMS announced an RFI, or Request for Information, about the new Medicare $2 drug list model. This week marked 2 years since President Biden issued Executive Order 14087, entitled Lowering Prescription Drug Costs for Americans. In that directive, he tasked the Secretary of the Department of Health and Human Services with selecting a test model from the Center for Medicare and Medicaid Innovation, referred to as both CMMI and the Innovation Center. 1 year ago, the Innovation Center came back with 3 models: the Cell and Gene Therapy Access Model, the Accelerating Clinical Evidence Model, and the Medicare $2 drug list model. And spoiler alert, the latter is the one that they chose to move forward with. That brings us to this week's request for information on the Medicare $2 drug list model. The model would essentially create a standardized list of Medicare-defined generic Part D drugs, allowing sponsors to, quote, offer a low fixed copayment across all cost-sharing phases of the Part D drug benefit up to the out-of-pocket limit, end quote. And while at first glance, a model like this doesn't seem like it should be necessary, that is not what the Innovation Center found in their research. When looking at data from the 2023 Medicare Part D landscape, they found that only 20.5% of Part D plans offered a drug benefit similar to what is outlined in the Medicare $2 drug list model. In the official RFI, CMS outlines the cost logistics of the new model. Quote, a fixed copayment of up to $2 for a month's supply and up to $5 for a 3-month supply across all cost-sharing phases of the Part D prescription drug benefit up to the out-of-pocket limit for a beneficiary, including those enrolled in low-income subsidy programs in a participating plan, end quote. The request for information goes on to detail how the Innovation Center came up with their sample list of drugs. 9 different criteria were identified, and then that information ran through what they call an external technical expert panel, or TEP, of physicians, pharmacists, and health policy experts. The sample list contains 101 drugs in a variety of strengths and formulations. So don't be surprised when you see over 270 fields in the Excel sheet, should you choose to download that document. A majority of the drugs are used to treat blood pressure and cardiovascular issues, with the next largest categories including drugs for mental health disorders, infections, and neurological disorders. Comments regarding the Medicare $2 drug list can be submitted until Monday, December 9th. We will have the link to all of the CMS documentation in our episode notes. So check that out to read the full request for information, download the sample drug list, and get the link to submit comments. I usually end these episodes by saying, that's all we've got this week. And that is true, but we did go over a lot of information in one episode. So make sure you check out the notes for links to all the official press releases and the link to send us a question, should you have one or several about any of the information that we covered here today. I hope you have a fantastic weekend. Stay healthy and stay safe out there, and we will see you next week. The Agent Survival Guide podcast is a production of Ritter Insurance Marketing, an integrity company. This episode was written and produced by me, Sarah Ruppel, script editing and fact check by Tina Lamoureux, podcast design by Urban Rivera, artwork by Vivian Zhao. Follow along with us wherever you like to listen.